So as I look at the results of that study, heart size tells us a lot, and the results of that study tells us that once the heart enlarges, if I give this medication, on average, we're extending their disease-free or symptom-free period by 15 months, which is 10% of the lifespan of a dog. And to me, that's a relevant amount of time.
Hey, VetFolio Voice listeners, thank you so much for joining me for this episode, sponsored by Boehringer Ingelheim Animal Health and featuring Dr. Brian Skansen and Dr. Sonia Gordon, who joined me live on the VMX soundstage to talk about management of mitral valve disease. This was such a great talk. It was standing room only at VMX, which was amazing. And I think that's because, since learning about the results of the EPIC trial, a lot of us have questions about how to manage mitral valve disease. I mean, this includes proactive management of predisposed breeds or patients who have a heart murmur but aren't showing any clinical signs of heart failure, as well as knowing how and when to intervene in patients who do become clinical and how to monitor those patients, when to refer them, all these questions that come up. And I will tell you, Dr. Skansen and Dr. Gordon were incredibly empowering, and they illustrated that there's a lot we can do in general practice prior to referral, but they were also very reassuring and letting us know they've got our backs when we do need to refer and when questions inevitably come up in these cases. As you can imagine with this topic, there were a lot of questions, so I'm going to go ahead and stop my remarks there and introduce our wonderful guests, and let's get started. Dr. Sonia Gordon is a professor of cardiology at Texas A&M University. She graduated from the Ontario Veterinary College, University of Guelph in 1994 and earned her doctorate of veterinary science in veterinary cardiology there in 1998. In 1999, Dr. Gordon became a diplomate of the American College of Veterinary Internal Medicine in Cardiology, and she's also a charter fellow of the Michael E. DeBakey Institute for Comparative Cardiovascular Sciences and Biomedical Devices at TAMU. She received the Richard H. Davis Teaching Award in 2004 for her excellence in teaching, and her research focuses on canine chronic degenerative valve disease, dilated cardiomyopathy, interventional cardiology, and clinical studies. Dr. Brian Skansen is a professor and service head of the Cardiology and Cardiac Surgery section at Colorado State University. Prior to this, he held a faculty position at The Ohio State University. He's published over 250 journal articles, book chapters, and abstracts related to cardiac disease in animals. He's also a founding member of the Veterinary Interventional Radiology and Interventional Endoscopy Society and serves on the editorial board of the Journal of Veterinary Cardiology. Dr. Skansen's clinical and research interests include congenital heart disease, advanced cardiac imaging, and minimally invasive treatments. Let's go ahead and jump into our talk.
Microbiome science is a swiftly evolving field that has caught the attention of pet owners. Are you prepared to answer their questions? NAVC's brand new veterinary microbiome certification course will give you the skills to implement microbiome science in your daily practice and improve patient care. New research shows maintaining a balanced gut microbiome is vital for optimal nutrition, disease prevention, and longevity in pets. Register today on vetfolio.com.
Dr. Skansen, Dr. Gordon, thank you so much for joining me today. All right, so starting off with the first question. 5-year-old Cavalier, breed we all love, walks into a bar. Just kidding. Walks into our clinic for a wellness exam, and we put our stethoscope on this Cavalier, and this beautiful dog does not have a heart murmur, and we're so happy. How do we approach the workup in this patient? Is it something we discuss with the owner? What do we need to be thinking about in that moment?
Absolutely. So a Cavalier, as any veterinarian knows, is unfortunately a breed that's predisposed to heart disease, and more specifically to mitral valve disease. So when we think about the evaluation of the Cavalier, I think a wellness visit, although often stretched for time, is a really ideal opportunity to at least begin the client conversation about heart disease. Many Cavalier owners are already aware that their dogs have a predilection, but if this is a new Cavalier owner that hasn't experienced the breed, maybe doesn't do a lot of research, I think that's the role of the primary care veterinarian, to at least not scare them, but make them aware that this is something we need to be mindful of for the future. And I think it sets the stage that the veterinarian can carefully listen to this dog. This is why annual evaluations are important. We're going to listen carefully every year. We're going to hope we never hear anything abnormal. But if and when that time comes, we're going to be prepared to deal with it. Heart disease can be scary, but it's also a condition that we can manage for years. So I think really the 5-year-old Cavalier is an opportunity to begin that conversation with the family.
That's really good advice to kind of set the stage there. If we do have maybe one of these more proactive owners who knows that heart disease is, kind of a reality with this breed, are there diagnostics that we should think of early if we have an owner who's up for that?
The nice thing about heart disease is that the ideal diagnostic that we have is our stethoscope when we're talking about degenerative mitral valve disease, which is going to be the focus really of today's conversation. There are other ways that we can screen for heart disease. In other breeds, maybe a Doberman, things of that nature, where we're worried about conditions that can be silent to the stethoscope. That's where we might consider screening tests like screening echocardiogram, or in a general practice setting, even a cardiac biomarker like NT-proBNP. Those can be clues that heart disease may be present. But if we're talking about a Cavalier, or maybe even expanding that to small to medium-sized, middle-aged dog, that's going to be our classic breed profile for mitral valve disease. In my opinion, the best screening test for when heart disease becomes relevant and where we might do something is auscultation. And that's going to be careful auscultation on an annual basis. I'd like to make maybe just a couple points about auscultation, because it's maybe straightforward to say we need to listen to their heart. But I think, as everybody is aware, in a busy practice setting, if you've got the door open and sounds of the outside coming in, if you've got kids from a family running around the exam room, if there's 2 dogs there, one's barking, that's going to really impair your ability to pick up subtle changes like an early heart murmur, or a systolic click, or an arrhythmia. And so auscultation is important, but so is careful auscultation and trying to optimize the environment so that we spend enough time listening over each valve area in a quiet, idealized environment. That's going to give us the best chance to pick up disease when it becomes apparent.
Absolutely. So thinking of this same 5-year-old Cavalier who didn't have a murmur, now we're 6 years old, we come back. Now this same patient does have a murmur. How does our approach change?
So for me, it's always good news, by the way. It's like, wow, I'm so glad you're back for your annual wellness, because this tool that I'm using to listen to the heart allows me to detect very early changes and start talking to you about what we should do about that. And today I hear an abnormal sound, which is a heart murmur. It's probably a leaky valve. It's really common. And it doesn't mean that we have to do anything except figure out for sure what it is, and is it something we need to do anything about. So I think it's actually a good thing, and you have to make them understand that you found something, but it's a good time to evaluate the murmur and see if it's important to this dog, because the disease we talk about is very easy to treat in the early stages and change the outcome for the pet. So I think you have to not scare them. They have to kind of be lulled into this sense of the fact that they're part of a nice team, and this is a good thing that we found the murmur. Glad you're here. Let's have a look and decide if that murmur is important.
Absolutely. That positive reinforcement of like, this is why we have you come in every year, because things change and we need to pick them up early. We're talking about mitral valve disease, of course. And like you said, to find out exactly what it is, where is this murmur coming from? How bad is it? What do we need to do? When we start getting into diagnostics, sometimes owners the eyes start to get wide and go, we're talking, okay, ECG, echocardiogram, chest x-rays, things like that. If we're talking to, say, maybe a more budget conscious owner, or just the idea of talking about the diagnostic workup and the different tests that are involved, that in and of itself is a little bit scary to them. I would love to hear your input on just communication tips and how to approach those workups.
I think the first thing you can say is the best part of it is the tests I'm going to talk to you about are easy, they're not painful, they're done in awake animals, and they're probably tests you're familiar with. You might have even had one yourself. But what we really need to do to assess the stage of this disease is to know how big the heart is. And so we need some sort of way of looking at the heart, and the stethoscope doesn't do that. So let's let's think of the tools we have. Well, we can use x-rays of the chest, which are quite easy to do. We might even be able to do them today. And we can look at the heart size. It's not the gold standard test for evaluating the heart size. That would be an ultrasound of the heart. And that's something that sometimes we can't sort of schedule on the day, right? These are things, but there's nothing urgent going on here. So there is a test called ultrasound of the heart or echocardiography that allows us to visualize the valves and the chamber sizes. And it's probably more accurate, if you will, and more sensitive and specific at telling us what's going on. But the radiographs are also very useful. And so if we start talking a little bit about budget-wise strategies, because the other part about the communication at this point is that I'm hoping that your dog, the heart is not big yet. And if that's true, we're going to have this conversation next year and maybe the next year. And so we're talking about repeating tests over time, because at some point when the heart is big enough, we're going to recommend a treatment. So it's kind of good to think about, and this is where you might want to share with them the price point of a radiograph and find out where their budget is. And I think it's hard for us to talk about money in veterinary medicine, and I think we have to do that. And we have to give people permission to live within their budget. And so as soon as you kind of, an ultrasound might cost around this and a radiograph might cost around this, but we can certainly get there with a radiograph, or we could start with a radiograph and use that as a way to sort of triage the situation and decide, well, what's the value of going on to an ultrasound of the heart? Because the radiographs might tell us the heart is really normal. We don't need to worry. We need to check again next year, but right now I'm willing to give you a clean report card. Or the heart might be big enough that even without an ultrasound of the heart, we can make a presumptive diagnosis and talk about treatment. However, if the heart kind of falls in the gray zone in the middle, we might be left with not a clear answer today. But we can still deal with that. I mean, that would mean that we either have to reflex and maybe think about that ultrasound at a later time, or we can repeat the x-rays of the chest at some maybe 6 months or 8 months. So we give them choices and try to have to kind of figure out, I think, where they land on that with respect to living within their budget. Yeah.
Sure. That makes sense. Dr. Skansen, am I putting you on the spot too much if I ask you to add to that and say, that question of if I can only pick one, how do you approach that?
I think it's a good question. The way I would frame it, I agree with everything that Dr. Gordon said, but in addition to that, I think there's what can be done today, and then there's also value in at least informing them what all their options are. And she alluded to that, but many times just the word heart disease, those two words scare the family, right? And so I do think there's value in a primary care setting, say, hey, we can get an x-ray today, and then we can have a much more involved conversation about how worried I really am. Right now, all I know is I'm hearing something a little bit abnormal about the heart, and that's scary, but it might not be anything we need to be super concerned about right now. I think it's also a good time, again, from an educational perspective. This is the #1 heart disease that we see in dogs. You can tell them 10% of all dogs will develop this disease. So this is not something crazy or new or unique. This is something that I see every day as a veterinarian. This is something that is common. And because of that, we kind of know the right way forward to figure out what your dog really needs. So you asked, what test would I choose? I think the way I would frame it in a primary care setting is we can get a lot of good information right here today with an x-ray. And if you want to know with 100% certainty exactly what is wrong with the heart and how big the chambers are, we can have you get an echocardiogram. Now, depending on the practice, that might be something that is feasible. If someone in your practice has an expertise or a familiarity or advanced continuing education in ultrasound, that could be something that could be done internally, or you could refer them to a cardiologist. That's how I would frame it. We can do a lot and understand a lot right now. You also have an option, if you so desired, to have a comprehensive ultrasound done at another time.
Both of those answers were really helpful. Got my wheels turning where I'm like, okay, there's some good talking points here where we can really make this a productive conversation and not a scary conversation with pet owners. Dr. Skansen, to your point, sometimes you say heart disease and that's scary. Owners hear heart disease and they have all these horrible ideas of what is going to happen to their pet. I know I've certainly talked to pet owners and said, some never progress to heart failure. Is there any way to kind of predict who might go into heart failure and who might just have this murmur and never necessarily show clinical signs?
Yeah, I mean, that's really what cardiologists spend a lot of time trying to figure out, because I think that's where we can do the most good for heart disease in dogs. If we could decide amongst this 10% of all dogs how we should prioritize who gets testing and who gets therapy, and can we delay progression of disease, those are the questions that I think are of most relevance to families and to those that care for these dogs. So I'll give you my perspective. We do know that across many studies, once the heart enlarges, and enlargement, can be a subjective thing. Is it big? Is it not big? Is it a little bit big? Is it really, really big? But in truth, we have defined cutoffs, both by X-ray and by ultrasound, that tell us that the heart has enlarged to such a degree that therapy will be beneficial. And so that's based on a clinical trial, the EPIC trial of 360 dogs. These dogs all had mitral valve disease. They all had at least a grade 3 out of 6 heart murmur. They all had heart enlargement on X-rays, and they all had heart enlargement by ultrasound. And that population was divided into two groups. Half received pimobendan and half received a placebo. And the results of that study were, I think, very revealing about how beneficial treatment in the asymptomatic dog with heart enlargement can be. Specifically, the results showed that it was about 15 months longer on average for the dogs that received pimobendan before they went into heart failure or died, as compared to the placebo group. So it took a few years for that result to become evident. And as that trial was happening, a lot of cardiologists wondered, will it show a positive result? And maybe even more importantly, if pimobendan is helpful, how much benefit are we seeing? Because in a lot of these studies, there might be a significant benefit, but let's say I have to give the dog a drug twice a day for 2 years and I extend his survival by a week. I don't know that that makes sense. It might be statistically significant, but it may not be clinically relevant. So as I look at the results of that study, heart size tells us a lot. And the results of that study tells us that once the heart enlarges, if I give this medication, on average, we're extending their disease-free or symptom-free period by 15 months, which is 10% of the lifespan of a dog. And to me, that's a relevant amount of time.
I would have to agree with you. If given the option to have my dog around for an extra 15 months, I know I would absolutely take you up on that. Dr. Gordon, did you want to add anything to that?
I mean, there was a groundbreaking, game-changing conversation point for me to be able to say to an owner that I can change your stars. Like, I can change what's going to happen. We don't have a lot of treatment that we know in a true preclinical or subclinical state alters the outcome. And I guess I always add, I make it a little light, and I'm like, I don't have a crystal ball. I don't, but I know that this disease progresses and it's different in different dogs. And I can talk about averages, but that's not your dog, but I can change it. I can reduce your dog's risk by a third every day for the rest of its life. On average, that's going to get you more than a year. So you kind of, because we all hate to share numbers with clients because the median is one dog. And I don't want to set expectations that can't be met. And this disease is slowly progressive unless it's not. But I can also empower them at that point to count breathing rates and be part of the team that detects the next threshold. So it's all about trying to make them part of it and part of the decision making and help them understand that it's a kind of a pay-as-you-go plan, right? Like you're investing in your dog's, future when we start this medication at the right time.
Sure. And just to clarify, we're talking about when the heart enlarges to a certain point, because kind of going back to the beginning here of who's going to progress and who's not going to progress. Am I understanding correctly that we're taking x-rays? Maybe we have a heart that is not enlarged. Maybe we get an echocardiogram and we're like, yes, we have more information. And so at that point, we're not going to start pimobendan, but we're going to continue to take those serial images, whether they're ultrasound or x-ray. And then when we get to a certain point, that's when we're seeing these statistics. Is that right?
Correct.
And what's the cutoff for, say, like vertebral heart score, for example?
The one, again, medicine is acceptable uncertainty. So based on a fairly large cohort of dogs, 11.5 on a VHS looks like a pretty good number, that, especially given these murmurs tend to be louder in dogs with more advanced disease. So if you have a a moderately loud, easy to hear murmur, and a VHS that's greater than or equal to 11.5, the degree of certainty is probably somewhere in approaching 85% or more. And then if you wanted to use VLAS in the same population, a 3.0 vertebral left atrial size is a slightly different objective tool to measure the radiograph. And so I don't think we have as much data to look at in terms of knowing the number, but certainly 3 is very big. Whether or not we should lower that, I think it's going to take some more data to know that. So, but very clear ways. And then you can also look at repeating the radiographs and looking for this time when you actually start to have an acceleration of increase in the heart size. So it kind of goes along, and then it takes off. And we call that the velocity of increase in heart size, right? And we've all watched this clinically. You see the dog and 2-3 years in a row, his heart's pretty static, maybe a little wiggle in the size, but not very much, And then all of a sudden he shows a pretty good jump. And a pretty good jump is probably 0.5 vertebral bodies over a 6-month period, because that's probably a little more than the average variability. So it probably represents a real change in size. And so we can look at repeating a radiograph on an individual dog and looking at the progression of their heart enlargement as another criteria. So if you measure their vertebral heart size today, and then they come in 8 months later, you can look at the difference between and divide by 8. And so if I said 0.5 over 6 months is relevant, simple math says that's 0.08 per month. I can't measure that, but I can know the time between 2 appointments and do a little simple math. It's all about how do we not hold clients hostage for an ultrasound of the heart if that isn't within their means, because the idea is to treat as many of the right dogs and give them the benefit of hemobendin treatment that we can, right?
Absolutely. And it sounds like mitral valve disease specifically is sort of working in our favor. I don't know if that's the right way to put that, but in terms of being able to really get some good information with our stethoscopes, we can hear this murmur get louder. We can watch the heart enlarge on x-rays versus some of our other heart disease, which Dr. Skansen, like you said, can be a little more silent, a little bit more insidious. That there's a lot of good markers that we can go off of, even if we can't get that echocardiogram.
Yeah, I think there's 3 inflection points that I think about with mitral valve disease that are really critical for the veterinarian to keep in mind. And to be honest, all of their dogs at risk, which is going to be a large amount of the small and medium-sized dog population as they age. And those 3 points, we've touched on 2 of them. The first is when it goes from no murmur to murmur. So now we know disease is present. And in the ACVIM staging, that means the patient has moved from stage A, at risk, to stage B, heart disease is present. Then the next step is when the heart enlarges to those cutoffs that we've been talking about. And that usually requires imaging, either X-ray or ultrasound or both. So 1 is development of the murmur, 2 is the development of heart enlargement. Now, in both of those situations, the dog remains asymptomatic. So the client is not aware there's anything wrong, but those are 2 big points for us. 1, to know the disease is here, and 2, to know when to intervene. And then the third inflection point we can talk more about, but that's when the dog shows outward signs, when they go into heart failure, have symptoms.
And I'm glad that you brought that up, because that's exactly where my brain was going next, was what about when we do start showing clinical signs? We talked about triple therapy, and then I want to say the most recent consensus statement also talks about spironolactone. So how do we approach medical therapy in a dog that is becoming symptomatic?
I guess to me, it's still all good news for a client, right? So I'm so glad that, we've been on this journey together and, we've probably had a nice extension of this asymptomatic time. But once they start to show us clues that the heart is having a hard time keeping up with the needs that the body has without building up fluid, right, in the lungs. So they usually come in with complaints of respiratory changes. I mean, cough is not the main sign of heart failure, but there's a lot of comorbidities in this population as well. And airway disease intersects very nicely with a big heart. And so it's going to be that the owner notices something new, right? Probably not chronic, but new. Like the dog was syncopal, there's an increase in respiration rate, the cough is new or worse. And I think that because part of managing them through the preclinical stage means now you have communication during that time, so they can become very savvy and notice. And if we can get them counting home breathing rates, right, the sleeping respiration rate is probably the most specific and sensitive way to detect that transition from B2 to C. And so we have to continue to find ways to get engagement from our owners on that because they still don't all do that. We try to help them understand why they're doing it. It makes it easier to pick up changes in the disease sooner. But so we get them in and then we're like, okay, now we need to assess this new sign, this new problem that we have. It might be associated with the heart. It probably is if it's respiratory and the dog has had chronic mitral valve disease, but not always. So we need imaging again, right? So ideally we need some tool to assess, is there, for instance, cardiogenic pulmonary edema? That's what we're all worried about. That's life-threatening. I mean, it's obnoxious to have a cough because your heart's big, but it's probably not going to kill you. And so this it's important to deal with because the owner's bothered, but we're all worried about cardiogenic edema because we know that means, if we don't take care of it, bad things will happen. And so the gold, point of care ultrasound is very good in the hands of people who are very good with it and identification of B lines and the like. That skill set is not an entry-level veterinary skill set. And radiographs are still probably considered the gold standard. If you suspect a dog has congestive heart failure or has something going on in the chest, you're probably going to do radiographs first. Even if I could do ultrasound, if I had to pick, it would flip for me. And the guidelines do that too. They say if you suspect heart failure, echo no longer wins, right? Because I need to know what's going on in the chest cavity. And so you'd want radiographs. You'd still get a chance to look at the heart size. You'd know if it got bigger. Or maybe that's the first time you've seen this dog. He's a new patient, right? So you might not have anything to compare it to, but you'll get a look at the heart size. You'll be able to see the parenchyma and say if there's a pattern of infiltrate that's consistent with heart failure. Dogs tend to read textbooks, right? They like caudal dorsal, perihilar distribution, kind of symmetrical, can get pretty bad, but often it's just, a mixed interstitial. And then maybe we can even see the vein well enough to know if they're enlarged. So we try to come up with that. Does the complement of evidence off the radiograph support the clinical suspicion based on respiration rate and effort in particular, that because you don't diagnose heart failure in a dog that doesn't have respiratory embarrassment, but does the picture come together and make sense clinically? And if you're not sure, let's say you're 80% sure it's heart failure, but you still have that niggling that maybe that's something else. The pattern's not 100% specific. You know what? Trial therapy with heart failure medications is a diagnostic test in and of itself. You can reevaluate both radiographs and clinical signs and then make that decision thereafter. So I think we have to, and there are other tests that would be, blood work. By the time you're using drugs like loop diuretics and ACE, like maybe those are, but the most important would be to have some idea of whether or not they fulfill the diagnosis criteria for congestive heart failure. And then that brings on a loop diuretic, pimobendan if it's not already there, and you can sneak up on polypharmacy. The goal might be 4 therapies, but nobody likes to be handed 4 therapies on a given day. Like sneak up on that stuff. An ACE inhibitor is not going to get that dog out of heart failure. Neither is spironolactone. Those are long-term insurance policies to try to optimize survival. Those can be snuck up on.
I guess, you mentioned the respiratory rate. If we don't have that data, is there any statistics numbers to say respiratory coughing not coming from heart failure, maybe being the heart being enlarged, pushing on the trachea or something like that? Because it is so tempting to squint my eyes when I see those and be like, oh, no, what if that is fluid in there? And I get nervous and going, what if I don't implement a loop diuretic and there is fluid there and I'm missing it? I start doubting myself and all of this. And then my brain goes even further down the rabbit hole. And I think about an ACE inhibitor, and do those have antitussive effects? Am I like benazepril or something like that? So then I go, well, am I masking this cough or something like that? So I guess my question being, can you offer us any tips for, like you said, this complement of evidence to stop me specifically here, and I'm hoping I'm not the only one who has this experience, from really, I guess, going to this place of catastrophizing things, going, yep, it's got to be heart failure, we're coughing, and what if I don't treat it correctly and it gets worse or something like that?
I think the most important thing I would say to that is start by looking at the patient. So what is the dog telling you? Now, if the dog is walking around the exam room, wagging its tail, and their complaint is cough, heart failure should be maybe a consideration, but that dog isn't telling me that he's in profound distress, right? So if you're equivocating on the films as to whether or not there's pulmonary edema, you have some luxury to sort that out. You don't have to catastrophize at that point. as compared to the dog that is brought back on a gurney that is abducting, stretched neck, cannot breathe, then at that point, I mean, give Lasix and then figure it out, right? So those are two very different scenarios. And I think starting with what is the dog telling you and what is the clinical complaint of the client. Now, you asked about the proportion of cough. Cough is a challenging feature in dogs because, as Dr. Gordon mentioned, there's this interplay between respiratory disease and cardiac disease in the older patient, and they go hand in hand in many dogs, unfortunately. And so sorting that out can be hard. But what I would suggest we do is, one, get X-rays if the dog is stable, and look at heart size. So if the complaint is cough and the heart size is not enlarged, he's not coughing because of his heart. So do things like the vertebral heart score, the vertebral left atrial size that Sonia mentioned. If those aren't reaching the threshold of heart enlargement that we've been talking about, 11.5 on the VHS, maybe 2.5 to 3 on the vertebral left atrial size, it's unlikely you're dealing with heart failure. It's more likely the cough is non-cardiogenic in that scenario. Conversely, if the dog's complaint is cough and the heart is enormous, then I would feel pretty comfortable presumptively treating for cardiac causes of cough. And there again, does he meet these thresholds? If he does, we know pimobendan is a reasonable drug to start. And I would start with pimobendan and talk to the client over the next week about the clinical response to that drug. So I think we have to frame it within those contexts. If we're talking about a dog that feels well and is coughing, take your time, decide whether you think the heart is big, treat that. If that's not working, then we can move on to other therapies, considering a trial of doxycycline, considering a trial of steroids, if we're not having luck with any cardiac medications at that point. That's a completely different scenario than the dog that is short of breath and struggling. And in that case, before I know it's heart failure, if I have a dog in respiratory distress and I hear a heart murmur, I would treat with Lasix and sedation and oxygen, reassess in 20 minutes, and we'll move forward. You're not going to hurt cancer by giving it Lasix. So let's treat what we know is treatable and what we have suspicion for, and then we'll make continued reassessments in that first period.
And I have one I would add to that. The EPIC study gave us a lot of information also about what happens to dogs as they approach heart failure, right? Because we looked at the two cohorts, and we know that home resting respiration went up by 60%, which means if you're trending an individual dog somewhere around 2 to 3 months before they presented for active failure in the clinic, they were showing signs. And the truth is the in-clinic respiration rate also changed, right? So months before, right? So I think sometimes respiration rate, panting is not a respiration. We need to be quite brutish about making sure we get a good respiration rate. And because there are other things that also happen as you approach heart failure that we can trend in our records, like heart rate. So for instance, if you have a dog that you've been seeing and you've been monitoring heart rate and respiration rate, and they're in and you're wondering if this new cough is potentially related to progressive heart disease and heart failure, and you can document a respiration rate above 40 in the clinic in a relaxed pet, or one that's maybe 38, but usually it's 24, and the heart rate is higher as well. So I think it's a matter of taking the balance of the information and the subtleties and looking at, where is there enough weight to go one way versus the other. And I think sometimes we fail to focus on some of the more simple things, and heart rate and respiration rate are very powerful. Also, those dogs tended to lose weight, body weight, and it documented very nicely that vertebral heart size starts to jump. So on that radiograph that you repeated, not only is the heart big, but if you have a prior one to compare it to, and there's been a jump in VHS between those two visits, the EPIC study showed us nicely that those are the dogs that are on that steep trajectory. And in fact, the VHS changed before the respiration rate. It was a marker of progression. Yeah.
I feel very reassured. Thank you. I appreciate that. I hope everybody else does too. Can I ask you to elaborate a little bit on spironolactone and an ACE inhibitor being these long-term insurance policies?
Let's now deal with the dog that is in heart failure. And it's not really the dog where you're squinting at the films. He's in respiratory distress and you feel reasonably confident. In that scenario, really, it's going to be the acute therapy that gets this dog out of trouble. That's going to be furosemide oxygen and sedation. As a sedative in the emergency setting, I usually use butorphanol. It has minimal cardiorespiratory depressing effects. and it's an anxiolytic, so it helps break the cycle of stress and respiratory difficulty. So we're going to stabilize the dog with those. Now, what we know from multiple clinical trials is that there are 3 medications that have proven to prolong the survival of dogs that are in heart failure. Those 3 medications are pimobendan, enalapril, and spironolactone. So if we know that those 3 medications prolong survival, we would like to get the patient onto those medications. Now, we use quadruple therapy because these dogs need Lasix. That's how we got the fluid out of the lungs in the first place. Interestingly, there's no study that proves a survival benefit to Lasix, furosemide, but that's because ethically nobody would run a study in which half the dogs did not receive furosemide. So we're going to have them on furosemide, pimobendan, enalapril, and spironolactone. But I think both for the pet and for the client, as Sonia alluded to earlier, it doesn't make sense to throw all of them at once because that's a lot. The other thing that happens often when the dog is hospitalized, they're scared, they're hyporexic, they're not eating well. Oftentimes, there's some kidney derangement as you are maybe pushing them pretty heavily with diuretics in the first 24 hours. And so we don't want to exacerbate any of that with an ACE inhibitor or even the spironolactone. I'll tell you, my typical approach is stabilization in the acute phase, send them home on furosemide and pimobendan, see them in a week, see how things are going at home. Is he breathing more comfortably? What have the respiratory rates been? Is he eating okay? Are there any signs that he's developing azotemia or side effects from the Lasix? If all of that's good, then introduce the concept that, hey, we're out of the scary acute phase. We can manage this disease for months, if not a year or more. And we know 2 other medications will help to prolong that survival, help to provide some benefit to the heart in the long term. And if they're open at that point to starting those, then it's at that 1-week recheck I begin enalapril and spironolactone.
That makes sense. Yes, because it's already scary enough to an owner to bring a dog in who's in heart failure. Those can be really dramatic cases. And then, yes, to say now give these 4 medications to your dog who is not eating well because he can't breathe is a lot. And so I think that feels like a really practical approach and a conversation that's very doable to have with owners. So I'm wondering next about referral. I think you have both been incredibly empowering, at least to me as a general practitioner, to say there's a lot that we can do in general practice to manage these patients well. At what point do we need to kind of tap out and say, nope, this is a referral situation?
So, I mean, the one I always tell students first is if they ask. I mean, any client that's asking, send them, right? Because you want to not get there. The other one for me is, if things are going sideways, right? Like something isn't going as expected. And it might be as simple as even a B1 dog that all of a sudden comes in and looks like they're a C, like they're in heart failure. And that's weird, right? There's probably something a little more advanced going on in that type of a dog. It might be that they develop new signs like right heart failure and you've been managing left heart failure, or they're syncopal now, or you're up titrating Lasix because they came back in heart failure and now you've given them more parenteral Lasix and this is their second round of hospitalization. So my value is really, when you're struggling, right? That's where and sometimes it could be as easy as a phone consult. But when things are sideways or at the end. So when we really start getting into what we would call stage D, which would be probably furosemide doses in the 8 to 12 mg per kg per day, and you're thinking about, do I need to do something different like add torsemide or change to torsemide, or or should I increase the dose of pimobendan, or can I address this comorbidity in a patient that wasn't expected and now they're having more struggling more with azotemia, or they've developed a new problem, or they need an elective anesthesia or not so elective anesthesia. So I think we're a great support team on your, in the back when you need us. And a lot of it can be handled, but I think we can do a lot to help, and especially the little art of finessing the advanced stage dogs and getting more out of them, including there's some palliative procedures that can be done. So a left atrial decompression procedure to try to sort of, you make a hole in the intraatrial septum so the right heart pays the price, but we can sometimes rescue some of these diuretic resistant dogs. So there's tricks up our sleeve. So when you need a rabbit, right?
Dr. Skansen, did you want to add anything to that?
I mean, I agree completely, and I think it will vary by the veterinarian, right? So I think, a new graduate that hasn't seen a lot of heart failure, if something doesn't feel right, that referral may come a lot earlier. If a seasoned veterinarian has seen heart failure dogs for 30 years and this one isn't acting like normal, that might be a different level of referral. So I think it depends on really the comfort of the veterinarian. But I think what I'd like to try and empower every veterinarian to understand is mitral disease is common. There's too many dogs with mitral disease to see a cardiologist, let alone the finances. We're talking about 8 to 10 million dogs. There's only 450 cardiologists. There's no way that every dog could see a cardiologist even if they wanted to. So I think it's important to understand we can evaluate dogs in the primary care setting for mitral valve disease. And with these kind of three inflection points, I think we can understand when to start therapy without having a cardiologist right there. But if something isn't going to plan or you need advice, that's what we're here for.
And if I would just add one thing, when you send them to us, we're not looking to take them. We want to be part of the team. So I've learned this even in human medicine that often we have an expert in one area and we have our primary care doctor and then we have another expert in another area and they all work together. And so I would look at it as a lot of co-parenting of these patients, which I mean, I enjoy because I get to hear a lot more about them. But I think it really might be that they see us sometimes or then you do some follow up and we share that. So I think there's lots of ways to navigate that where we're actually working together as a team.
Sounds like really, just kind of customized patient care. Like, what does that patient need? What level of specialized care does that patient need? What level of follow up on a primary care level? Well, if we're talking about mitral valve disease, I'm a gator, and so I feel like we have to talk about surgical options because certainly we have open heart surgery, but there's other surgical procedures as well now to address mitral valve disease. Can you expand on some of those a little bit?
Yeah, so I think we teach mitral valve disease almost as if it's a deficiency of these drugs we've been talking about. When in reality, none of the drugs fix the problem, right? The thing I like about cardiology is at its base, it's pretty simple. Blood has to go one direction. If blood's not going that direction, we're going to have problems. It's functionally a plumbing problem, right? So the medications prolong life, they limit symptoms, and that's huge. But they don't actually address the primary issue. The primary issue is leakage of the mitral valve. And to fix that, we either have to stop that degeneration from ever happening. I don't have that cure in my toolbox. Or we have to fix the leak once it has established itself. So in human medicine, for decades, that was done with open heart surgery. That is an option for dogs. And currently in the United States, the University of Florida is where that is done. The challenge is one, the expense. It's very expensive. And number two, availability. Even if your client has the money, currently it's over a year wait to get in for open heart surgery, which may be too long for that specific patient. So in human medicine, they also recognize not every patient can undergo open heart surgery. If you're talking about an elderly individual with comorbidities of lung disease, cancer, renal dysfunction, that's a prohibitive risk for open heart surgery. And so they have developed transcatheter therapies where they can fix mitral regurgitation without stopping the heart, even in the awake, sedated patient without bypass. These therapies are often things like clipping the leaflets of the valve together. And I say that, one, because you may have a family member that's experienced a procedure like that, but two, we now have that as an option for dogs. So there is what's called the V-clamp procedure that results in a transcatheter edge-to-edge repair. And that's available at several centers across the United States. We've done over 100 cases at Colorado State University. The University of Illinois has a program, Tufts University, VCA West Los Angeles. So there are centers that you can go for an edge-to-edge repair. The reality is surgery is probably able to fix the most different forms of valve leakage and degeneration, but at very high expense and at pretty high involvement for that patient. The edge-to-edge repair can't fix everything. It has to be the right anatomy, but it's at lower expense and less invasiveness.
So my approach to talking to clients about this right now is, especially if they come in asking, if they ask, can you do heart transplants in dogs? The answer is still no. It's a hard no, right? But if they asked, does valve surgery get done and is there a good outcome? I mean, the weights are horrible, the cost, the logistics, but the survival rates are screaming high, 95, 98% in the teams that are doing this. And we're talking probably repair that is very durable. Maybe never going to be a problem for your dog again, right? Maybe even the medications can be reduced and taken away. The edge to edge is a very nice approach to dramatically changing the leak pretty quickly, maybe reduce it by 50%. That resets the clock like crazy, right? That's going to really help. So if they come in asking, and you know that even there's weights for some of those things, and these are not conversations you necessarily need to have. I would say they come in asking, that's a cardiology referral. You know, they don't have to go to one of the centers. They just need to go see a cardiologist because you don't have the face time to spend with them. And it's hard to stay current on all that stuff. And so it might be the conversation I have in particular with the young dog with fairly advanced disease, because likely their life will be abbreviated. So if they're a 6-year-old dog and they're a B2, you know, a B2 could last for a lot of years, but if they're the kind of person who would pursue a procedure, then setting up a referral to discuss that and think about where they land on that and get, you know, and if you say the $15,000 price tag and they run screaming from the building, then they probably don't need to worry about that. Or $30,000-$40,000 for an open repair on a beating heart. So, you know, so I think that there's conversation to have, but it's in the lay press. So it's likely that some of your clients will come in asking about it, and it hits the papers, and you know what I mean? So nice for you to kind of know where the state of the art is, or the state of the heart.
I love it. In our festival of hearts here.
In our festival of hearts.
Well, I feel, really reassured on a lot of these points, and thank you so much for just spelling this out so practically, so beautifully. Are there any final thoughts you want to share?
You can treat heart disease. It doesn't need to be scary.
And you can learn how to ultrasound hearts. The basic scan is a very doable thing. It is not an entry-level skill. I still feel bad about that. But ultimately, measuring the left atrium, it is the report card for most heart diseases, so it wouldn't just impact your ability to treat this disease. It would help with cats. It would help with others. So trying to invest, or if you have an interest, right, find a way to get some advanced training. It is something that these, focused exams that answer very practical questions can be incredibly non-radiation producing, right? Minimally invasive, all the right words.
All right, I want to say a huge thank you to everyone who joined us. I hope everybody got as much out of that episode as I did. Dr. Skansen, Dr. Gordon, thank you so much for joining me. What a great talk. I want to say a big thank you to Boehringer Ingelheim Animal Health for making this episode possible. And thank you to all of you out there listening, whether you joined us live at VMX or you're tuned in listening wherever you get your podcasts. If you did enjoy this episode, please leave us a 5-star review wherever you get your podcast. It'll help other veterinary professionals like you, or so I'm told, find this and other great content we try to put out there. For more episodes, click on the education tab on the VetFolio website or find us wherever you get your podcasts. We are always eager to hear your thoughts and ideas for future episodes. Feel free to reach out to me at dvm@vetfolio.com. We can connect on Facebook at dr.cassiedvm or follow me on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day. Important safety information. Adverse reactions not related to disease progression in dogs receiving vetmedin CA1 pimobendan included diarrhea, vomiting, pain, lameness, arthritis, urinary tract infection, and seizure. The safe use of vetmedin CA1 has not been evaluated in dogs younger than 6 months of age, dogs with congenital heart defects, dogs with diabetes mellitus or other serious metabolic diseases, dogs used for breeding, or pregnant or lactating dogs. Conditionally approved by FDA pending a full demonstration of effectiveness under application number 141-556. For more information, see full prescribing information or visit vetmedinca1.com. That's vetmedinca1.com. Important safety information. Vetmedin, pimobendan chewable tablets, and vetmedin solution, pimobendan oral solution, are for use in dogs with clinical evidence of heart failure only. The most common side effects reported in field studies were poor appetite, lethargy, diarrhea, dyspnea, azotemia, weakness, and ataxia. Vetmedin should not be given in case of hypertrophic cardiomyopathy, aortic stenosis, or any other clinical condition where an augmentation of cardiac output is inappropriate for functional or anatomical reasons. For more information, see full prescribing information for chewable tablets or full prescribing information for solution.